Welcome back to the deep dive. We are looking at a stack of clinical notes today that, honestly, it reads less like a medical chart and more like a logic puzzle.
It really does.
We're tackling a condition with a notoriously heavy name chronic suppurative otitis media, or CSO, but the mechanism behind it is, well, it's just fascinating. We're going to be breaking down the case of a 64-year-old farmer, let's just call her Mrs. XYZ, who presents with a classic yet completely paradoxical symptom.
It is a total paradox. It's one of those little details. If you just skim the chart, you'd miss it. But if you know what you're looking for, it basically tells you the diagnosis before you even pick up an otoscope.
Exactly. I'm talking about something called paracusis willisii. So Mrs. XYZ comes in. She's complaining of hearing loss right ear for 6 months, but, and this is the hook, she says she hears better when she's in a noisy environment.
Right, so she's in a crowded market or a loud barn, and suddenly things get clearer.
Which just runs contrary to every instinct we have about hearing loss, you know?
Of course. Usually, background noise is the enemy. It just masks everything. But for her, that noise is actually helping her hear the conversation.
And this is where the source material gets interesting right away. This isn't just a quirk, it's a mechanical fingerprint. It tells us immediately that her auditory nerve, the wiring, is likely intact.
Oh, for sure. If she had sensorineural loss, that background noise would just be a wall of static. She wouldn't understand a thing.
Right.
Sensorineural loss is a clarity issue. It's like listening to a radio that's slightly off station. If you turn up the volume, you just make the distortion louder.
But Mrs. XYZ has a volume issue.
Exactly.
Yeah.
She has conductive hearing loss. The wiring is fine, but the signal is blocked. And when people in a noisy room start talking louder, it's called the Lombard effect.
Yeah.
They overcome that blockade for her. She hears better because everyone else is basically shouting.
But the notes go even deeper than just that. There's this incredible concept mentioned about the discharge in her ear, the round window shielding effect. This just blew my mind.
It's pure physics in action.
The idea that the infection itself, you know, the gunk, is acting as a kind of makeshift prosthetic.
It is. So for the cochlea to register sound, you need fluid to move inside it. That fluid moves between two little windows, the oval window and the round window.
Okay.
But here's the catch. There has to be a phase difference. The sound has to hit one window a split second before the other. If sound hits both windows at the exact same time, the forces just cancel out. You get zero movement, zero hearing.
And in a healthy ear, the eardrum creates that delay.
Precisely. But Mrs. XYZ has a huge hole in her eardrum. So in theory, sound should be hitting both windows at once and canceling out. But she has this discharge, this fluid, sitting right over the round window.
So it's blocking it.
It's shielding it. It's delaying the sound wave just enough to restore that phase difference.
So in a twisted way, if you were to clean her ear out completely, you might actually make her hearing worse for a little while.
For a moment, yeah.
Yeah.
You lose that shield. The pathology is literally propping up the function. It's a very specific clinical picture.
Okay, let's talk about that pathology. We need to profile the villain here. Mrs. XYZ reports discharge, that is, and I quote, scanty, foul-smelling, and yellow. Now, looking at the microbiology cheat sheet in our sources, that yellow color points us pretty clearly towards Staphylococcus or Streptococcus, right?
Yellow usually does, yes. If we were seeing green, we'd be thinking Pseudomonas, which is a nightmare to get rid of.
Yeah.
If it were that curry white color, we'd be looking at Candida, a fungus.
But Mrs. XYZ has yellow, but the color isn't the most alarming word in her chart, is it?
Not even close.
It's the smell, foul-smelling.
And the quantity, scanty.
That seems so counterintuitive to me. I mean, you'd think a huge pouring infection would be worse, but the notes say profuse, odorless discharge is actually safer.
It usually is. It suggests a mucosal issue.
So why is the scanty, foul combo the big red flag?
It's because of what's being destroyed to create that smell. Mucus doesn't inherently smell, foul.
Yeah.
But bone does. That foul odor is the scent of bone necrosis, osteitis. It means the infection isn't just irritating the lining of her ear, it's eating into the actual architecture of her skull.
So scanty implies it's deep and destructive, not just surface level. That puts us squarely in the dangerous category. Adicoantral disease.
Correct. We are now dealing with a bone eroding process. And once you realize bone is being eaten away, you have to look at what's next door and what's right next to the ear.
The brain, the facial nerve.
The balance system, everything, which explains the next phase of her exam, the interrogation, you could call it. The doctor spent a lot of time on what she didn't have, the negative history.
Like she had no vertigo.
A crucial negative. If she had vertigo, we'd know the erosion had breached the labyrinth, the inner ear. That's labyrinthitis. The fact that she's stable on her feet means the inner fortress hasn't been breached. Not yet.
She also reported no pain, which again feels really odd for a bone-eating infection.
That's the insidiousness of it. Acute infections scream at you. Chronic infections whisper. The lack of pain is probably why she waited 6 months to come in.
But if she did have pain,
If she had deep, boring pain, we'd be having a very different conversation. We'd be worried about intracranial complications.
the notes bring up something called Grad-Negos syndrome here. This sounds like the worst case scenario.
It is the danger zone. Grad-Negos is a triad. If the infection spreads to the very tip of the temporal bone, deep in the skull, you get 3 things. 1, ear discharge.
Got it.
2, retroorbital pain, meaning pain behind the eye. And 3, diplopia, double vision.
Because it hits the 6th cranial nerve.
Exactly. The abducens nerve. It paralyzes the muscle that moves the eye outward. If Mrs. XYZ had mentioned double vision, she wouldn't be in a clinic. She'd be in an emergency neurosurgery suite.
Wow. Okay, so luckily she's negative for that, and negative for neck rigidity, so meningitis is off the table for now. But we have to talk about lifestyle factors. The notes are so aggressive about smoking.
It's entirely mechanical. It's not just a general health warning. The ear it's like a self-cleaning oven. It has mucociliary clearance,
These are the tiny hairs, right?
thousands of them, all beating in rhythm to sweep debris down the eustachian tube. Smoking paralyzes those little hairs.
So the broom just stops working.
The broom stops, the ventilation stops, and the whole system becomes a stagnant swamp. But even more critically for her, if she's a smoker, the surgery she needs is almost guaranteed to fail.
Because the graft won't take.
The graft just dies. You're trying to reconstruct this delicate eardrum with a tissue graft. If the patient is smoking, the tiny blood vessels are constricted, oxygen supplies choked off.
Yeah.
It's a disaster. We made patients stop for weeks beforehand.
Okay, let's move to the physical inspection. The doctors finally get hands-on. They start with the outside of the ear, and I noticed they did the Tregall test. I'm guessing that was negative for her.
Correct. The Tregall sign pressing on that little flap of cartilage is the classic sign of otitis externa swimmer's ear.
A skin infection.
A skin infection of the canal itself, yeah. And it's excruciating. But her problem is deep inside the bone. You can wiggle her ear all day long, it won't hurt. It's a great way to tell skin deep from bone deep.
Then they looked at the mastoid bone behind the ear, looking for something called ironing out. That's such a vivid image.
It is. The mastoid surface is normally a bit rough. If the air cells underneath are full of pus and pressure for a long time, the skin over it stretches. It can look smooth and shiny, ironed out. It's a subtle sign of underlying mastoiditis.
Now we get to the main event. Looking inside with the otoscope. We know there's a hole, but the notes focus on the handle of the malleus. It's described as foreshortened.
This is such a critical observation. The malleus is the first little bone in the hearing chain, and it's attached to the eardrum. If the ear has been struggling with negative pressure for months because the eustachian tube is blocked,
It sucks the eardrum inwards. It retracts.
it retracts deeply. And this tilts the malleus, so when you look at it head-on, it just looks shorter than it really is. A foreshortened handle tells you this isn't a new injury. This ear has been under vacuum pressure for a very long time.
Which brings us to the tuning forks. I know some people think they're old-fashioned, but the notes make a strong case for them. They started with the RIN test.
The RIN test is the bread and butter. You're just comparing air conduction to bone conduction. In a healthy ear, air is always better. You'll hear the fork longer next to your ear than you will with it pressed on your skull.
But for Mrs. XYZ, it was the opposite. Bone was louder than air. A negative RIN.
Which is the classic sign of conductive loss. The blockage in her ear is stopping the airwaves, but the skull bone transmits the vibration perfectly, bypassing the whole mess.
Then the Weber test. This is the one on the forehead. For her, the sound went to the right, to the bad ear.
And this is one that always trips people up. Why would the broken ear hear it better? It's called the masking effect.
It's because her bad ear is essentially plugged, right? Like putting a finger in your ear.
Exactly. You can try right now. If you hum a low note and stick a finger in one ear, the hum gets louder in that plugged ear. You've just blocked out all the room noise. That ear is now in a soundproof booth, listening only to the bone vibration.
So her infection is acting like that finger.
Her infection is the finger. It isolates the ear, so the bone signal comes through crystal clear, while her good ear is distracted by all the ambient noise in the room.
That makes perfect sense. So the tuning forks confirm a pretty severe conductive loss. Finally, they did the fistula test, pumping pressure into the ear to see if it made her dizzy.
Right, they're checking for a third window, and erosion into the inner ear. If it's positive, her eyes would deviate, or she'd get this intense vertigo.
The notes say negative, but they also drop a warning about false positives. So you can get a positive fistula sign without a fistula.
You can. It's called Henneberg sign. You see it in things like syphilis or Meniere's disease. Basically, fibrous bands can form that pull on the inner ear structures when you apply pressure, mimicking a hole.
It's a reminder that biology is messy. It's so messy. A test result is just a data point. You have to interpret it in context.
Okay, let's put it all together. We have a 64-year-old with painless, scanty, foul-smelling discharge. Conductive hearing loss confirmed. No major complications yet. The diagnosis is chronic suppurative otitis media, specifically the adicoantral type.
Also known as squamous disease. And the primary suspect here is a cholesteatoma.
Let's unpack that term because it sounds like a tumor.
It's not a cancer, but it behaves like one.
Sure.
It's basically a skin cyst. Skin is supposed to be on the outside of your body. In this condition, skin cells get trapped inside the middle ear.
And skin is always shedding.
It's always shedding. But inside a closed space, those dead skin cells have nowhere to go. They build up, they get infected, and they release these enzymes.
Enzymes that dissolve bone.
They eat the little hearing bones, they eat the mastoid bone, and if you let it go, they'll eat the thin plate of bone separating the ear from the brain. That's why the discharge smells. It's rotting bone and decaying keratin. Which explains why the treatment plan isn't drops. They're scheduling a modified radical mastoidectomy.
You can't dissolve a cyst with drops. Antibiotics won't clean out dead bone. You have to go in there surgically and get it out.
The name of that surgery is intense. Modified radical. What are they actually doing?
It's a renovation, really. They drill out the mastoid bone behind the ear to remove all those infected air cells. Then they remove the bridge of bone, separating the mastoid from the ear canal. What you're doing is converting this complex multi-room structure into one single smooth cavity.
Common cavity.
Exactly. By removing all the nooks and crannies, you prevent the cholesteatoma from hiding and coming back. You make the ear safe.
And the notes list this hierarchy of goals for the surgery. I found the priority list very telling.
Oh, that order is non-negotiable. Goal number 1, a safe ear. That means removing the disease so she doesn't get a brain abscess or meningitis, life over function.
Number 2.
A dry ear. Getting rid of the discharge so she can live a normal life.
And strictly in third place, a functional ear.
Hearing preservation is a bonus. It's a last priority. In this type of surgery, we try to rebuild the hearing mechanism, but only if the ear is safe first. We generally don't promise patients hearing improvement. We promise safety.
That's a sobering trade-off. We're going to drill into your skull to stop the bone rot, and maybe, just maybe, you'll hear a bit better.
But you have to look at the alternative. If Mrs. XYZ ignores this for another 6 months, that scanty discharge becomes a headache. That headache becomes a fever. And suddenly we are dealing with temporal lobe abscess. The stakes are just incredibly high.
It really reframes the whole idea of an ear infection. We think of them as these little childhood annoyances.
Right.
But this is a slow-motion structural failure of the skull.
It is. And it highlights why the clinical exam is such an art form. We didn't really need a CT scan to figure most of this out. We just needed to smell the discharge, watch how she reacts to noise, and use a $10 tuning fork.
It is detective work in its purest form. All the clues, the yellow color, the foreshortened malleus, that Weber test, they all build this watertight case for surgery.
And it reminds us to really listen to the patient's specific, weird complaints. When she said, "I hear better in noise," she handed us the key to the whole puzzle.
Which brings me to a final thought for you to take away. We talked about the false positive with the fistula test, how the body can signal a hole where there isn't one. It just strikes me that we live in an era of data overload, where we treat every symptom or health tracker notification as this definitive fact.
That's a great point. We see a number on a watch or a symptom on Google and we jump to a conclusion.
But as Mrs. XYZ shows us, context is everything. A signal that sounds good, I can hear better in a noisy room, is actually a sign of serious disease. A signal that looks bad dizziness when pressure is applied might be a false positive.
You need the interpreter.
Yeah.
You need someone who knows that scanty is worse than profuse. Data without wisdom is just noise.
So next time you're in a crowded restaurant and you realize you can hear the conversation perfectly clearly, maybe just book a checkup, just in case. Thanks for diving in with us.
Always a pleasure.